with today's topic. We'll talk on PET in cardiology a little bit. It's a long talk, so I'll try to run through the slides a little bit quicker. If you have any questions, feel free to stop. Ask me any questions that you feel. So nuclear cardiology has been around for a while. We started with planar cardiology, then we have SPECT with ECG gating was added, attenuation correction was added. We do MAGA scans for EF evaluations, and then there's PET in cardiology or cardiac PET. Then that's going to be the focus of the talk today. So cardiac PET can be done for either myocardial perfusion imaging similar to SPECT with rest and post-rest images. The stress can be pharmacologic or exercise depending on the agent used. Most of the time it tends to be pharmacologic though, but for some it can be exercise, especially when you use ammonia as the tracer agent, and you use it for evaluation of coronary artery disease, ischemia, chest pain, and those kind of things, similar to SPECT perfusion studies. And it can be used for cardiac metabolism imaging, where you do a rest perfusion scan. It could either be with PET or it could be with SPECT, but usually we prefer PET, followed by an FDG metabolism scan of the heart. And we do that to evaluate myocardial viability, scar tissue, especially when you're doing EP ablation procedures, and for infectious or inflammatory conditions involving the heart, like cardiac sarcoidosis, myositis, and those kinds of things.
So the radio tracer, you don't use FDG, you use rubidium-83.
For perfusion. For perfusion, we use rubidium-83 or ammonia, N13 ammonia. It's actually rubidium-82, or it's a typo here, it should be 82. Rubidium-82 or ammonia are the perfusion tracers. For cardiac metabolism, you use FDG. Okay? So you're looking at different things. So SPECT has been around for a long time. It's got fairly good accuracy. It's easily available. Accuracy is increasing with ECG gating and attenuation correction. It's proven to be cost effective, and it's generally an established modality, but it's got several disadvantages. This is a 39-year-old female with chest pain, cardiac SPECT to assess for ischemia. She's a little bit obese, BMI of 45, not a little bit, but anyway, BMI of 45, typical southerner patient here. And you can see that there are abnormalities on the rest and stress images, and basically the resolution is poor. You can hardly see the cavity pretty well. On the contrary, so this was basically read as infralateral defect suspicious for true perfusion defect, TID suspicious for multivessel disease, LVEF of 63%, study limited by body habitus and breast attenuation artifact, can have similar appearance. Subsequent left heart cath was completely normal basically, or no significant disease. So a lot of times with obese patients we have this, and that kind of limits the SPECT. So the disadvantage of SPECT are it's got somewhat suboptimal spatial resolution, limited temporal resolution. It's got inadequate attenuation correction. It's got longer acting half-life radio tracers, so that translates to higher radiation exposure to patients, especially if you use thallium, and makes the protocols much more inefficient. Things are changing with SPECT though. You are getting better resolution with the newer scanners, and especially with the solid state detectors, the resolution is pretty good. So this is more, in the future it might be pretty good. Right now it's got these limitations though. It also has got regional relativity, so you basically have problems evaluating something called balanced disease or balanced ischemia, where if you have multi-vessel, so you're basically looking at one vessel distribution and compare it to other and see if there's decreased tracer uptake. And so if there is a multi-vessel abnormality or triple vessel disease, all the vessels, territories are down, and so it becomes difficult to compare it relative to the other bed, and you can miss significant ischemia based on that. And they have a relatively low first pass extraction fraction, and so at higher flow rates you can underestimate the tracer uptake. And usually with ischemia, because of the body's reaction to ischemia, the flow rates are increased in ischemic myocardial bed to compensate for the decreased blood flow basically. So that causes problems as well. So all these kind of translate to advantages for PET. You have better spatial resolution, higher temporal resolution, PET was always developed with attenuation correction, so the attenuation correction algorithms are superior and more robust to the SPECT attenuation corrections. The half-life of the PET tracers is pretty low. For ammonia, it's about 10 minutes. For rubidium, it's about 75 seconds compared to 6 hours for technetium and even longer for thallium. So that translates to much more efficient protocols and less radiation exposure to the patients. There is a good way to quantify absolute quantification of blood flow, so that gives much more robust evaluation of the myocardial perfusion, and you can detect less or smaller defects or hyperperfusion, and it gives you more precise and consistent measurements of for when you're doing repeat studies or serial studies. This tends to be more useful compared to SPECT. So the main advantage is the ability to quantify global and regional myocardial blood flow in ml per minute per gram of tissue, which correlates well with CAT values that we get. And you can assess regional perfusion abnormalities with relative myocardial perfusion imaging, which is an issue with SPECT because you always are comparing to the other bed. And you can basically get a handle on endothelial dysfunction as that. So it is a little more accurate at detecting severe as well as minor coronary disease, and fares well when patients have multivessel or triple vessel disease with the balanced ischemia phenomenon I just mentioned earlier. And so here is a patient with 47-year-old female, atypical chest pain, dyspnea, high risk for coronary disease, and BMI of 50. And these are again SPECT images, stress, rest, and again you can see that once the BMI is high, the SPECT kind of suffers, and you think there's something here, or this breast attenuation. The septum is not really looking good either. And yes?
On that previous patient, I think morbidly obese, 50 BMI, 50 patients, do we still go with SUBSTRATE first, or should we consider PET?
We should consider PET.
We should consider PET.
So that's the study limited by patient body habitus motion artifact. And so the same patient, you see the stress images, and you can see that.
So, just quick interruption. So what would a health insurance company would say?
So it is approved for high BMI patients, basically obese patients. PET is approved by insurance companies as well. And so you can see that the PET resolution is much more superior to SPECT. You can clearly see abnormalities even in these patients. The patient clearly has a defect which is predominantly reversible in the apex and apical portion of the heart, and you can quantitate it with the SSS and SDS, some different score of 8, which is abnormal, moderately abnormal, so that the score is strongly suspicious for ischemia. This is a relatively recent example actually. Last month we scanned this patient, so you can clearly see the difference in the quality of images with the BMI of 50. I think they were about to, she may already have had CAT, and I'll look for it and see what the CAT correlation showed. You can get much more different kinds of information. We gauge the rest and the stress. The EF is 63 on both, so did not fall down much with stress, and you get a nice summary here with all 3 axes, the TID, the rest and stress perfusion, the ischemia and SDS score and all that information. And you also actually get a probability of survival, 95% 1 year. It's just a little more, lot of information that you can get because of the quantification and other parameters that PET can provide. Here's another patient, 45-year-old male with diabetes and cardiac risk factors, BMI of 46, height 5'5" to 80 pounds, and you can see again the quality of images. It's just pristine in spite of a high BMI. Completely normal study. This was done, I think, almost 5 or 6 years back, and the patient is still completely normal and asymptomatic. So a good positive and negative predictive values. So same patient, EF of 70%, At rest it was 68%, so pretty good again, no wall motion abnormalities. So there are different tracers for cardiac PET. The perfusion tracers are, you can have N13 ammonia, which is approved by FDA. There are these two tracers that are still in the research arena. O15 water is considered the most ideal tracer, but it's not easily available, and it generates more data than images. So you actually get values. It's very difficult to interpret the images because the images are very noisy. And F18 fluoropyridase is still under research arena. It's still in clinical trials. If this gets approved, it would solve a lot of issues that we have with ammonia or rubidium. The rubidium is a generator-produced tracer, meaning you don't need an on-site cyclotron, but the generator is a fixed expense. You have to lease it for a year, and it costs about $50,000 to lease a generator for a year. So you need a steady stream of patients and adequate patient volume to make it cost effective. Ammonia, it's cyclotron produced, but the half-life is 10 minutes, so your imaging lab should be quite close to the cyclotron. Otherwise, every 10 minutes you're getting only half the tracer. So it's rigorous on your resources, and you have to run the cyclotron several times for rest and stress doses and those kinds of things. Give me 1 second. So F18 fluoropyridase is another perfusion tracer which is in phase 2 trials right now. If that gets approved, then you'll potentially have the choice of on-demand cardiac PET tracer with the patient-ready dose shipped to you, and so you won't have to lease a generator. You don't need an on-site cyclotron, and you don't need a steady volume. So for centers that have low cardiac PET volumes, that would be a pretty good alternative, but it's still not FDA approved.
For radio tracers like this that are produced via cyclotron, you still have to send them to a lab.
Usually the lab is right next to the cyclotron.
Okay, but here that doesn't happen. What would you do with the rubidium that is 10?
Rubidium is not cyclotron produced. Rubidium is generator produced. You milk the generator.
The one that has a very little half-life.
Rubidium has a half-life of 75 seconds. You don't need to send it to the lab. It's the whole setup is FDA approved. Just like in the past, before you started working here in nuclear medicine, we used to have tech generators where you just Molly-Tech generator, you just milk the generator and inject.
Okay.
You know,
Right
or you tag it with whatever you're tagging the technician to. So it's the same principle of a generator. For ammonia, we do have a GMP compliant lab. We are a radiopharmaceutical production facility, so you have to do the QC, QA, and release the reports, especially if there's any abnormal growth or anything 3 days later. So you have to do all the things which a regular drug would do. Any other questions? So ammonia is a cyclotron-produced tracer. Half-life is about 10 minutes. It's got a smaller MBV, so that its range in tissue is less. So these parameters are kind of similar to F18, so the images are better compared to rubidium. It's got a high extraction rate, prolonged myocardial retention. You usually inject about 10 millicuries, wait for about 5 minutes, and then get a set of images for both rest and stress. You can get dynamic imaging, especially if you are looking for myocardial blood flow. And since the half-life is 10 minutes, you could do an exercise stress test as well as a pharmacologic. It's a little tricky, but we have done several ammonia studies with exercise, treadmill exercise. With rubidium, it's just not possible. You have to do pharmacologic stress tests. This is the mechanics of how ammonia is taken up via the glutamine synthetase pathway and gets trapped as N13 glutamine within the myocytes. And so there's metabolic trapping, and it stays there, pretty high extraction fraction in the first phase of the blood flow. This is the protocol. You inject the ammonia, wait for about 5 minutes, get resting images, wait for about 50 minutes, do the stress. If it's pharmacologic, you inject that peak effect of the dose. If it's treadmill, you inject a few minutes or a few 30 to 45 seconds before patient is going to stop. Wait for about 5 minutes and get the stress images. The whole procedure takes about an hour or 70 minutes or so. The half-life is 10 minutes, so if you wait about 60 minutes here between the two sets of images. It's 6 half-lives, so all the residual uptake of the rest is gone. So you can give the same dose for rest and stress compared to technetium same-day studies where you give 1-to-3 ratio. So you give a low dose rest and a high dose stress, 10 to 30. You don't have to do all those kinds of manipulations here because the half-life is low. Okay, and in SPARTA giving 10 to 15, it's usually 10 millicuries doses. So the radiation exposure to the patient is less because the half-life is less. So the radiation exposure to the patient is determined by how much time it resides in the body, the tracer. In this case, it's less because of the low half-life. 57-year-old female with breast implants, cup size 38C. So this patient is prone for breast attenuation artifact, which you usually see in the distal anterior wall. You can see that it's hardly affecting you. You can see that there is slight, it's not 100%, but you can see there's minimal thinning here. But overall, the image quality is pretty good for the patient size, and it's still a pretty diagnostic study. So this is just to show the value of this in obese patients. Pretty good EF, 76%, pretty good images, quality. You can see the cavity pretty well, no TID, nothing. Another patient, 51-year-old with exertional dyspnea, chest pain, angina equivalent, bra cup size 44DD. And that, you can see that there is a slight, but it's pretty similar on both. So it's not 100%, but it's, these patients would almost be uninterpretable on a SPECT scan. So compared to that, these are pretty good. Although you can see that, ultimately it's still going to have some limitations. So if you have a 500-pound patient, then it might be even worse. Yes?
Very little breast artifact.
Yeah, very little. It's not completely gone, but that does not make the study uninterpretable. And the good thing is, it is pretty much stable on both. So there's no differential attenuation correction or anything like that. So that kind of helps as well. And then some stress score 16, rest score 50. So pretty similar artifacts and some different score of 1, which is normal basically. Less than 0 to 4 is basically relatively normal. 61% EF and 64 at rest. No wall motion abnormalities, and again the same information, and you can see that this is the artifact that it's picking up. So relatively similar. In fact, it might be a little worse on the rest. That shows again that it's artifact. So same thing that we do with SPECT. You use the segmental model and you divide the walls into apical, mid, and basal, or proximal, mid, and basal. And you have the anterior wall, you have the lateral wall, you have the inferior wall, and you have the septum, and each is divided into various parts, and then there's an apical segment. So you use the 17-segment model, same for SPECT. And you look at various parameters, visual interpretation. You need to look at the location of the defect. Is it in which wall and which portion of the wall? So if it's in the anterior wall, is it proximal, mid, or distal? Same for any other walls. Then the severity, is it significantly down, or is it just mildly down, or it's kind of intermediate? Size, if it's large, restricted to more than, or is it restricted to one segment of the myocardium? And then whether it's reversible, fixed, or mixed. It could be predominantly reversible, or it could be predominantly fixed, or it could be mixed, meaning there's a reversible component around a fixed defect, indicating peri-infarct ischemia, basically. So all those descriptors need to be in your report when you're giving any read on a cardiac study, and then comment on the ventricular size, whether it's dilated. Then go on to look at the function, see if there are any global or regional wall thickening abnormalities, whether the EF is decreased, look at any cavity size changes between the rest and stress images, if there's any transient ischemic dilation, and all those things. And after that, look at the qualitative or quantitative analysis that the software gives, so that you can have the sum stress, sum rest, and some different scores. And so the sum stress score, basically, what they do is they look at the drop in the perfusion or in the tracer in each segment and score it. So 0 is normal, 1 is slightly reduced, 2 is moderately reduced, 3 is severely reduced, and 4 is absent. and then they do it for the stress images, then do it for the rest images, and then subtract the stress from the rest to get an SDS, and then there are various parameters. So if you're looking at just the stress scores, less than 4 is normal, 4 to 8 is mildly abnormal, 9 to 13 is moderately abnormal, and more than 13 is severely abnormal. But usually just interpreting it using the SSS or some stress score is not that good an option. Always look for SDS as well, because if the SDS is 0, then all these SSS abnormalities have a matching abnormality on the rest images, meaning it could either be infarct or it could be an artifact, and so you have to look at the at that to interpret the SSS. So the SSS alone is kind of not that great, but it does have some prognostic information. The more important is the SDS, where 0 to 1 is normal, 2 to 4 is mild ischemia, 5 to 7 is moderate ischemia, and more than 7 is severe ischemia. So that other patient I showed you had an SDS of 8, which is severe ischemia actually, so that's not good. And this one considers both the SDS and, the SRS and the SSS, so it's a little more reliable, especially for ischemia evaluation. That is the major indication in most of these studies, okay? Quantitative approaches is the, who's texting this? Quantitative approaches, myocardial, basically you have that, then you have the polar plots, and you have the SDS. Look at everything, the semi-quantitative and the quantitative analysis cannot consider artifacts. If there's a motion artifact, if there is attenuation artifacts, it's not there. So you have to have a visual. So just don't read by the polar plots or the scores. Always look at the slices and the splash images and make up a mind whether the defect you're seeing is real or artifactual, and then come up with a answer. Look at the raw data to see any misregistration in PET density. In SPECT, you look for motion artifacts. You look for any breast attenuation, motion artifact, non-coronary patterns, and then come up with your conclusion about what the study is showing. Rubidium, we don't do rubidium, so I don't have much images on rubidium, but you have, it's generator-produced tracer, so you don't require an on-site cyclotron. The half-life is 75 seconds, not 73, sorry, I said 73. It's 75 seconds. It's pretty short-acting, but the MEV is slightly higher, so it travels a little more in space, so the resolution is minimally suboptimal compared to F18-based PET images or ammonia-based PET images, but it's not significant. It requires an active sodium potassium pump, ATPase pump, for intracellular transport, so it's similar to potassium or thallium in its action. The dose is slightly higher, so you usually give about 45 millicuries or so, the range 30 to 60. As we are getting better and better scanners, the doses are going lower and lower. So the newer time-of-flight scanners or something, you might get away with just 30 millicuries. And that translates to, so in spite of a higher dose, because the half-life is so small, the overall radiation exposure from rubidium is actually lower than ammonia or any other technetium-based studies, or even thallium. It's much faster study. You could, if you do it regularly and have everything pinned down to all the T's and all the I's, you could potentially do a stress study with rubidium PET in 30 minutes. You're done. Instead of SPECT takes about 3 to 4 hours, ammonia takes about an hour or so. So this is the most efficient protocol, but slightly higher dose.
So one thing I can add, if you see the R rubidium, this thing really, really fast, like seconds.
Rapid.
Yeah, rapid. There you go.
Rubidium is rapid. So this is a slightly higher dose. Now you inject for 30 to 45 millicuries. So patient is on the scanner. Okay, the generator is actually in the scanner room, and you milk the generator and immediately inject and immediately start imaging within a minute or so. Get rest images. You have to wait a few minutes at the most. 10 minutes is good enough. Do the stress at peaks, and it has to be pharmacologic because the patient is on the scanner. You do the Alexa scan injection within a few seconds. Inject the second dose of rubidium, and then immediately start the stress images, and you're done. So pretty fast protocol. Okay. These are not my images, so but again, similar quality of images compared to ammonia. This is a normal perfusion scan. Female patient, this is a SPECT scan. You can see that the quality is not that great. You can hardly make out the cavity and all the details. Took more than 3 hours. Same patient, you can see that it's a pretty good quality study, normal, usually 30 minutes to an hour. Another patient, thallium, you can really see that, you hardly see the cavity with thallium, because thallium, the spatial resolution is even poorer than technetium-based scans, and the radiation dose is higher. So on the contrary, same patient with rubidium, pretty good images. And if you look closely in this patient, you can see that there's TID cavity. This is the rest, this is the stress, this cavity is slightly dilated. So this patient actually has TID, which is a sign of balanced ischemia actually.
Three vessel disease.
Three vessel disease, triple vessel disease. LVEF dropped with stress. That's another bad sign if you do a stress and the LVEF drops. So with rubidium, you get the purest EF and perfusion match because it's happening almost at the same time. Okay, with most others, so with SPECT, you do the stress and you get the images 30 minutes to 60 minutes later. Okay, with ammonia, you get it about 5 minutes later. With rubidium, you get it within a minute. So if the stress induces any functional changes, it is most likely to be picked up on a rubidium scan than a SPECT scan. Ammonia sometimes, but still by 5 minutes, usually patient comes back to normal. Okay, so these are the closest to the stress abnormalities that you can pick up. So we can see that the drop in LVEF with stress more with rubidium than with anything else. Okay. So current indications: patients who have body habitus that can cause suboptimal SPECT, female patients, obese patients, muscular patients who had a prior suboptimal or equivocal SPECT, in whom the SPECT scan did not correlate with the clinical findings on a subsequent angiogram or clinical impression, in patients whom you want to measure the coronary flow reserve or myocardial flow reserve, in patients whom you want serial measurements for consistent measurements to assess progression or regression. So all these are the current indications. So a BMI of 45, certainly you should be getting a PET rather than a SPECT. Quantification, myocardial blood flow and myocardial flow reserve. Basically, we like to call it myocardial blood flow, not coronary blood flow or flow reserve, because we don't get epicardial blood flow information with PET. We only get myocardial blood flow information. So we like to call it MBF or MFR. And it's the ratio of stress versus rest myocardial blood flow is the myocardial flow reserve. So it's basically another parameter that can help you prognosticate the risk for the patient. And the MFR correlates pretty well with the invasively determined cardiac flow reserve on angiograms and CAT. And basically, I already said this, and you get it in ml per minutes per grams. And for ammonia, the values are about 0.71 at rest, range is 0.61 to 1.1, and at stress it increases to 2.58 with the range of this, and a flow reserve of 3.54. For rubidium, it's slightly higher. Take this with a pinch of salt because these were with normal volunteers. Usually when you're evaluating these patients, they have risk factors, they're older and those kinds of things. Diffuse atherosclerosis and microvascular disease can affect the stress MBF, and hence it can affect the flow reserve. So it kind of decreases the specificity, but at the same time, if the flow reserve is significantly low, or preserved, then the negative predictive value is pretty high. So anybody who's got a flow reserve of greater than 2, the patient's chance of getting an MI is pretty low. And having a high grade disease on angio is pretty low as well. But if it's not, the specificity and positive predictive value is not that high, but the sensitivity and negative predictive value is pretty high. Okay. So when do you use this? So you basically use it as a more of a global status of the patient's myocardial blood flow and reserve to see if the patient has any high risk angiographic CAD. If you have a global stress myocardial blood flow of greater than 2 and MFR or flow reserve of greater than 2, then you can reliably exclude presence of high-risk angiographic CAD. The negative predictive value is greater than 95%. So that's one of its strong points. At the same time, if you have a severely reduced stress myocardial blood flow and the flow reserve is less as well, then that patient is at high risk for major adverse cardiac events, and basically they should be followed up more closely. You probably want to do a cath soon and confirm the disease. So in general, if you have a flow reserve of less than 1.5, they're considered high risk, and you need stat cath basically for those patients. And if you have a severe reduction in stress myocardial blood flow or flow reserve to less than 5 in a single vascular territory, then basically it suggests that you have a flow limiting CAD on cath, and those people are benefited most by stenting or balloon angioplasty and those kinds of things. If there's global, then this patient probably need CABG or aggressive medical management and put on the heart transplant list. Okay, so this is just some examples of how the flow reserve correlates with angiogram and all that, but for the essence of time, I'll kind of pass on it. So in clinical practice, this is still evolving. So all this is without any cath or without any arterial lines or anything like that. So that's pretty robust advancement to get blood flow without an arterial line or invasive cardiac catheterization. But you do require dynamic image acquisition. So mostly you get static images. For this, you require dynamic images over a 5-minute period. So it's a different acquisition mode on PET, and that's why it's a little bit difficult on SPECT. People are trying to get this kind of information on SPECT, but it's still in infancy. But you need to talk with your cardiologist and come up with a consensus about your thresholds and your values. And we have talked with our cardiologists here actually, and they see value in this. But it has to be a collaborative approach. You can't just start throwing out these numbers. It will confuse your cardiologist if they're not used to getting these kind of things. So it has to be developed in consensus with your cardiology folks, not just start doing it kind of a thing. And this is the ACC meeting last month in Salt Lake City. There was a center from Salt Lake City that basically presented that data when they transitioned from SPECT to PET completely for cardiac imaging in 2013, and they analyzed more than 10,000 patients. And so they had around 3,400 SPECT technetium-based studies and 7,000 rubidium PET studies over this period of time. They were fairly matched for age and gender. And what they found was PET helped them a lot. The diagnosis of severe CAD went up. Who underwent angiogram within 60 days also went up. And so diagnostic, not only their cath rate went up, but their positive cath rate went up. So patients who had cath they found disease, rather than the first example I showed where the SPECT was abnormal but the cath was normal. So it's basically like a useless cath. You should not have done it kind of a thing. So those false positives went down, or normal caths went down. So most of the caths, so you're picking up disease much more accurately, and you're triaging patients who need cath more accurately with PET than SPECT. And so that's what those findings were showing basically. So they were more successfully identifying these patients. Since it's a PET CT, if you have a 64-slice CT as a part of your PET CT, you could technically do an angiogram and have a very wholesome analysis of the patient's perfusion as well as the vessels, and see if there is obstruction and whether that obstruction is having any consequence of reduced blood flow, whether there are collaterals or anything like that. And so that would be the protocol for that. This is how it would look, and you could basically throw in the patient's own angiogram rather than a default angiogram to see where the problems are and what territory is what's the culprit lesion and all that stuff. lots of centers don't have a 64 slice CT as a part of their PET CT. They usually have a 4 or 16 slice, but that would be good enough for calcium scoring. So you could throw in a calcium score as well with that. And if you have a normal perfusion image, but there's heavy plaque burden with calcium, then that patient, that information is helpful for managing the patient prognostically. You need to do a little better medical management because the patient has high plaque burden. Similar to motion artifact on SPECT, on PET you have to look for misregistration. You can see that there is a defect here, which is because of this misregistration between the CT and the PET image. If you fix it, the defect is gone. So you need to take a look at the registration and make sure that what you're seeing is registered appropriately, otherwise you have false defects. Yes?
Are you seeing the misregistration on the SPECT images or the actual donut images over here?
What's that?
These donuts, is that showing the misregistration that we're seeing over here in the SPECT?
So this is the defect, okay?
Okay.
These are the splash images, and if you just read these without looking at the registration, you'll call this an abnormal study.
Right.
Right?
I thought you said on the fused image.
So you can see that this is a stress and arrest image. This is a reversible perfusion defect in the anterior wall. Positive study, send the patient to CAT.
Correct. But it was misregistered.
But it was misregistered, and so when you correct the misregistration, it becomes a normal study.
Now it's right. I got it. Thank you.
Okay, so looking at this data, so you're in a hurry, you usually just look at these, look at the polar plots and get done with it.
Yeah.
You have to do your QA, QC on each patient, otherwise you'll be burned. Okay? It's a CT scan, we get a few slices. Bad luck, you might miss a lung nodule. So take a look at the CT in the lung window as well. It's happened. I mean, I'm showing you a case, so it's happened. And then that's a loss.
Was that a case? Was that doctor's case? The one that said in the corner.
So anyway, this turned out to be small cell lung cancer. So moving on to metabolism imaging, the myocardium is very complex in its metabolic needs. It uses free fatty acids as well as glucose for its metabolic needs, and depending on what the metabolic substrate is, you have tracers that can look at the fatty acid metabolism or glucose metabolism in the heart. So you can use either FDG or C11 palmitate or acetate for looking at various aspects of metabolism. So accordingly, we have various myocardial metabolic PET tracers. F18 FDG is only the FDA approved one. C11 has been tried in research purposes. So all practical purposes use F18 to look at glucose metabolism in the heart. The problem is the heart uptake is very variable. So normal myocardial substrate utilization is very different. In fasting conditions, or high fatty acid levels, low plasma glucose and insulin levels, the primary myocardial substrate is free fatty acids. In postprandial conditions, when the glucose levels goes up and insulin levels goes up, consequently, or in ischemia or hypoxic myocardium, the primary substrate shifts to glucose. So basically, myocardial uptake can be highly variable. It depends on the hormonal and metabolic milieu when you inject the tracer and available substrate concentration. So patient's dietary preparation is very important, and also the indication of the study is very important. So basically, sometimes you want the normal myocardial glucose uptake to be suppressed, and sometimes you don't want it to be suppressed, depending on the indication of the study. And so yes, sarcoid versus viability evaluation, the prep is completely different. So when you're looking at myocardial viability for chronic ischemic heart disease, dysfunctional myocardium, or for SCAR, you basically want it to be normal. Whereas in myocardial infection or inflammation imaging like myocarditis or cardiac sarcoid, you basically want to suppress the normal FDG uptake. So the prep for this patient group versus these patient groups is completely different. And it will ruin your study, completely ruin your study. It will become an uninterpretable study. So it's very important that this be told to the patients and patient educated about it. So for evaluation of viability and SCAR, you want to shift the glucose metabolism, you want to shift the myocytes to glucose metabolism. So you can do that with dietary prep, glucose loading, insulin euglycemic collab method and acipimox, which is not available in the US. We use a modified or combination approach. We tell the patient to have a high carb, low fat diet on the day prior to the scan, so a couple of meals. High carb, you want everything to shift to glucose. You tell the patient to have a high carb, low fat breakfast 1 hour prior to the scan, and then depending on what the blood glucose is, we actually might give an oral glucose loading dose, so dextrose solution basically, to even promote more glucose myocardial uptake. And so this is what we do. If the BSL is less than 110, we give 25 to, we usually give 50 milligram dextrose solution, and then check the blood glucose, and then administer. If it's greater than 110, if the blood glucose goes too up, we might give insulin, but we try to avoid it. Usually up to 200, I try not to give it, just do the scan, and it works out pretty well. Sometimes we might give intravenous glucose if the patient cannot tolerate it, but we usually don't do it. This is apparently the best method, but it's very rigorous, and so most centers don't do it. Acipimox is a nicotinic acid derivative. It's used in Europe, but it's not available here. It indirectly promotes myocardial glucose uptake, so it kind of somehow enhances glucose utilization in the heart. And on the other hand, when you want to suppress the myocardial uptake of glucose for evaluation of inflammation or infection, you want to shift it to free fatty acids. So you tell the patient that the various methods are prolonged fast, dietary modification, or IV heparin, which basically activates the lipoprotein and hepatic lipases, the unfractionated heparin, and increases free fatty acids and hence reduces the glucose utilization of myocytes, or a combination of two. So what we do is we do a low carb, so reverse, high carb versus low carb, high fat diet and high protein, followed by an extended fast. So at least 12 hours of fast, not 18 hours, but 12 hours. And nothing on the morning of the scan. And we have to tell our patients what is high carb and what is low carb diet, basically. I mean, our patient population is not the most educated sometimes, so we have to. So we have a whole list of things that what they can eat and what they cannot eat and all that stuff. So why do we do this? So if you have a patient with chronic ischemic heart disease, you get repetitive ischemia or chronic hyperperfusion or acute occlusion, you get an ischemic insult to the myocardium, and you have an adaptive response from the myocardium because of the insult, and you can either have hibernation, stunning, or ischemic preconditioning. And the resultant myocardium could be normal, fully viable, it could be partially viable, or it could be non-viable. And basically you have this term dysfunctional myocardium, which could mean necrosed or scarred myocardium, which is non-viable, or it could be just stunned and hibernating myocardium, which is basically viable. And the management of a viable dysfunctional myocardium versus non-viable dysfunctional myocardium is completely different, and that's why it's important. So coronary artery disease with left ventricular dysfunction, you can have medical management, revascularization, or cardiac transplant. Okay. So medical management, in spite of all the advances in medical therapies, you can see that this is with medical therapy, the incidence of ischemic events and cardiac deaths is significantly higher to surgery. So surgery is kind of preferred. Surgery meaning revascularization. Cardiac transplantation is limited by availability of donor hearts. So you have either CABG or angioplasty and those kinds of things. But they have a significant peri-procedure morbidity and mortality, so it's not without risk. So you want to choose the patients who are going to benefit the most from this kind of. So if the patient has non-viable myocardium, this is useless. Okay, so you are basically going to do a procedure which has got significant peri-procedural morbidity and mortality with no benefit. So that's what we want to avoid. We want to use this procedure only on patients who are going to benefit. So only on patients who have viable myocardium. Okay, and that's the whole point of this exercise. So methods to evaluate myocardial viability: stress echo with low dose dobutamine, thallium, rest redistribution studies. Technician maybe sometimes can be used. PET with perfusion, cardiac CT, and cardiac MR. So as of now, PET with perfusion and FDG metabolism imaging is still considered the gold standard for evaluation of myocardial viability. cardiac MR is pretty good at it and may become the gold standard, but cardiac MR is not performed that routinely, and it has got some limitations as regards selecting the patient population and all that. So yes, it is good, but still it is not considered the gold standard. So how do we do it? So we have dysfunctional myocardial segment. If it's relatively normal blood flow, it could be stunned myocardium. If it's significantly reduced blood flow, it could be scarred myocardium. Intermediate decline in blood flow, it could be hibernating or necrosis, and that's where we have the problem so rest perfusion alone or perfusion imaging alone cannot be used to determine viability. You need something else. So you need something in addition to assessing the blood flow. So it requires blood flow in combination with metabolism. So we do either a rest, SPECT, or PET study and combine that with an FDG metabolism study. So that's the protocol. Glucose loading, if necessary, ammonia, perfusion image, and then wait for about 50-60 minutes so that ammonia effect is gone, and then do the metabolism image for FDG. And we get 3 possible patterns. You have normal blood flow and normal metabolism, which is normal. You have decreased blood flow and decreased metabolism, that's basically necrosed or scarred non-viable myocardium. Or you could have decreased blood flow with normal or increased metabolic uptake, and that is the hallmark of viable myocardium. So flow metabolism mismatch is the hallmark of viable metabolic myocardium, and that's what you are looking for when you're looking for viability. So this is just to show some images. You can see that the patient has a rest perfusion defect and FDG uptake there is preserved. So that flow metabolism mismatch is the hallmark of myocardial viability. Okay, so usually if there's a resting perfusion defect and a stress perfusion defect, match defect is considered infarct, right? So infarct kind of implies that it's dead, but it may not be dead, it may still be viable, and that's why you need this information. Okay, so again we can have the similar patterns of reading with the same software. You can get how much is the viable tissue. So this is a patient, 61-year-old with history of STEMI, multivessel CAD on left heart cath, myocardial viability study. So this is FDG, this is the rest ammonia, and you can see that there is a defect at the inferolateral wall, distally near the apex, and you can see that the FDG is a little bit down as well, and you basically get this resting perfusion, but the FDG is smaller, so there is this infarct or dead, but there's surrounding area of viable myocardium, and you can actually quantitate how much grams and how much percent of myocardium is matched versus mismatched. So this mismatch, so this 79% of the defect is actually mismatched and viable. So 80% of this defect is actually viable. So that's pretty good quantification. So the total defect is 14% of myocardium, which translates to 26 grams. 79% of the defect was mismatched or viable, and 11%, that's 11% of the total myocardium. 21 grams of myocardium is viable, and 21% is matched or non-viable, so that's only 5 grams. For cardiologists, this information is very important, and you could translate it to number of segments. If you have 2 or more segments that are viable, then you should go for revascularization. Another patient, 56-year-old, yes?
What was the threshold?
2 myocardial segments. 56-year-old male with history of, so this is actually 2 segments. If you go here, you can see that it's this and this, so mid and proximal. Another patient, 56-year-old male with history of ischemic cardiomyopathy, low LVEF, significant coronary artery disease on left heart cath. This is viability study again. You can see that there are multiple defects and multiple abnormalities on FDG and that scan. You can see that there is a distal anterior and apical defect, 91% mismatch. So that's 90% of this defect is actually viable. Okay. On the contrary, there is also a defect in the inferior or infralateral wall, okay, which 66% is matched. So 65% of the defect is scar, only 35% viability. So if you want to revascularize the anterior, distal anterior territory, because that has got most chance of a successful revascularization procedure, because the myocardium there is mostly viable, 91% viable. Okay, if you do a angioplasty or a stent of this vessel, it's probably not going to help because the myocardium there is mostly dead. It's not going to come back even if you restore the blood flow. Okay, so that's kind of the significance. So detecting viability predicts functional recovery, predicts improvement in CHF symptoms, exercise improvement in exercise capacity, improvement in quality of life, predicts cardiac events, remodeling, and long-term survival, and it also predicts perioperative complications and short-term survival. So this is an integral part of patients' workup in this situation. And if you identify viable myocardium in a patient with chronic ischemic heart disease, then that actually suggests a need for prompt revascularization. If you don't do it, then that can cause suboptimal outcomes for the patient, including death. So then they need, once you prove on a study that this patient has viable myocardium, the cardiologists need to act pretty soon. Okay, and at the same time, failure to identify any significant viable myocardium helps them to, triage the patient to aggressive medical management and maybe put the patient on a heart transplant list. Okay. These are, so usually we don't do stress portion, but sometimes we do it, and these are the various patterns. You have a fixed perfusion defect and a matched metabolism defect that's usually seen with a transmural MI. You could have a fixed perfusion defect but preserved metabolism mismatch that suggests a hibernation. You can have a partially or partially reversible defect with loss of metabolism. That's matched defect, non-transmural MI and ischemia. And you could have a partially reversible defect with preserved metabolism, mismatched defect, which can be seen with repetitive stunning. So there are various patterns, and you need to know what these indicate confidently. For scar imaging, it's very similar. Instead of viability, you're looking for non-viability or scar. And why do you do this? You do this in patients who have arrhythmias and they want to ablate it. So within the scar tissue, there is a track of abnormal signals that they can follow and ablate. And so the EP people are doing a lot of these studies, and they're also doing cardiac MR these days for that. Actually, Dr. Sangster has done a few as well. And so you're looking for your match defect. And so this is a patient that we did, had a big scar in the posterolateral wall, proximal or basal lateral / posterolateral wall. And they went to EP, and these are the EP maps, or electroanatomic bipolar voltage maps. The color code is, greater than 1.5 MeV is purple, and scar is red, which suggests less than 0.5 strength, millivolt strength. And within the scar area, there's usually a tract that is causing the arrhythmia that needs to be ablated. So if they go blindly, then they have a significant large area of heart to cover. It becomes very tedious procedure. If they know where the scar is, then they focus on that, and that this patient had successful ablation, and it controlled the patient's arrhythmias actually. So that's another indication for these kinds of studies. Quickly moving on to cardiac sarcoid, we have got 5 minutes. So it's a granulomatous disease of unknown etiology, causes non-casing granulomas, multi-organ involvement. Heart can be one of this. Symptomatic cardiac involvement is seen in less than 5% of patients, but asymptomatic cardiac sarcoid in autopsy is not that uncommon. When it does affect the heart, you can have conduction abnormalities, ventricular arrhythmias, heart failure, and patients who have symptomatic cardiac sarcoidosis involvement have poor prognosis compared to without cardiac involvement. There are no currently accepted international guidelines for the diagnosis of cardiac sarcoid. Okay, there are 2 proposed diagnostic guidelines. One is by the Japanese Ministry of Health and Welfare set of criteria, and another is from the National Institute of Sciences, this WASOG group, basically, WASOG group. And so these are their criteria, and it depends on whether you have a histopathological diagnosis of non-cardiac sarcoid, and you basically are looking at, so one of the criteria to diagnose is actually, this might is PET or you look at cardiac MR. So those are the two main modalities on imaging that you look for. So if you have a histological diagnosis of extracardiac sarcoid and the patient has some concern for cardiac sarcoid, you could do these. And so you look at, there are three basic patterns. You could have diffuse uptake, focal uptake, or focal and diffuse uptake. And so diffuse uptake is not that bad, but if you see focal or focal and diffuse uptake, that's basically a problem on PET. And here you want to suppress the normal myocardial uptake. So the dietary prep is different. And so again, you use it in concomitance with perfusion imaging, and you could basically get various patterns. So these are the guidelines for imaging, whom to image basically. So if you have patients who have extracardiac sarcoid and then they have arrhythmias or palpitations or other ECG abnormalities, then they recommend either cardiac MR or FDG PET. And again, this is done by multiple groups. So this is another group that came up with this algorithm. This is another group. So they all say that you could use one of those two modalities. And this is what you get in cardiac sarcoid with perfusion and metabolism. So this is normal. So when the cardiac uptake is suppressed, FDG uptake is suppressed with proper dietary preparation, you'll get a noise image, you'll get nothing. So that's normal and normal perfusion. So this is normal. You have diffusely increased uptake. This is probably normal, but patient did not do diet preparation well. So you're not able to suppress the uptake. So this is probably a non-diagnostic study. If you have a normal perfusion and intense so this is bad. This is either infection or inflammation in this area. In the appropriate circumstances, this could be sarcoid. And again, you can have a defect but suppression. So this is just a perfusion defect. And similarly, you can have other abnormalities. You can have focal defect or focal increased uptake in the same area or in a different area, and all these have different categories. So basically, category 2 and 3 are kind of abnormal. And these are proposed diagnostic criteria for screening. And actually, if you have an extracardiac sarcoidosis diagnosed and one of these patterns that are suspicious for cardiac involvement, you don't need a biopsy confirmation. It's considered diagnostic enough that this is cardiac sarcoid. So this is what I use for my guidelines for interpretation of cardiac sarcoid, rest perfusion and FDG uptake. So if there's normal perfusion and no or low uptake, heterogeneous diffuse, then this is normal suppression, this is a normal patient. There's no evidence of cardiac sarcoid. If you have normal perfusion and one area of increased uptake, but the rest is down, which is because of normal suppression elsewhere. So this area is abnormal because the rest of the heart there's no uptake because of the proper dietary suppression of FDG. So that's suspicious for sarcoidosis involving the heart. If there's no perfusion abnormality, that it probably indicates an early stage involvement. If you have mild perfusion abnormality with a similar pattern, that's progressive disease. If you have moderate perfusion abnormality, again increased uptake, that's more progressive involvement. And in severe cases, you can have severely increased and absent perfusion basically. And when it's fibrosed, you'll have no perfusion, and again there's no metabolism because it's fibrosed. So by this case, usually the patient is pretty far out and it's hopeless. So you usually don't do scans for this, but up to here you can. And we've had a couple of cases that fell in this category actually. And so here's an example. He has a patient, 47-year-old female, impaired left ventricular function, and she was found to have left bundle branch block. Concern for cardiac sarcoid. You can see that the perfusion is normal. Most of the heart is suppressed, so that's good dietary preparation by the patient. But the lateral wall, there's an increased area. So this is probably early stage cardiac sarcoid. Now we send this patient to New Orleans for management. They did not do a biopsy. If they had done a biopsy, we would have had a nice case report, but they did not do a biopsy because I don't know why. Unfortunately, this patient does not have a biopsy-proven extracardiac sarcoid. We found a lung nodule that lit up that looks granulomatous. Pulmonary is just following it. So I don't have an extracardiac sarcoid diagnosis either. This is the protocol for our cardiac sarcoid, low carb, high fat diet, extended fast, ammonia, rest perfusion, and then you do the cardiac metabolism, and then I throw in the whole body just to see if there is any sarcoid involvement elsewhere because it's a multisystemic disease. Here's another patient. You can see this patient actually has history of sarcoid, biopsy-proven extracardiac sarcoid present history. Now with cardiomyopathy and decreased LVF, so there's concern for cardiac sarcoidosis. You can see that the perfusion is normal and no uptake. So this is optimal patient prep. So this would be, come on. This would be normal for cardiac sarcoid, no involvement by cardiac sarcoid. And you can see that this patient has typical sarcoid pattern. So there is extra cardiac sarcoid, but no evidence for cardiac sarcoid involvement in this one. This one has a 27-year-old.
Lambda, right?
What's that?
Lambda.
Lambda, yes. We call that lambda or Christmas tree pattern. Lambda is more with gallium, but yes, it's the same. 27-year-old male, morbidly obese, abnormal SPECT perfusion imaging, but normal left heart, CAT subsequently. Decreased EF felt to be non-ischemic cardiomyopathy, but subsequently had non-STEMI. Then developed ECG abnormalities with concern for myocarditis or sarcoidosis, basically. And you can see that this patient has a perfusion defect in the apex and some increased uptake there. But basically in the lateral wall, there is slightly increased in the proximal or basal lateral wall. There is an area of increased FDG uptake, but the perfusion is normal there. So, when they did the scan, they were focusing more on myocarditis. So I didn't do a full whole body scan, but this pattern can be seen either with cardiac sarcoidosis or myocarditis kind of a thing. So we told them to focus on this. Again, they sent this patient to New Orleans, and we don't have any feedback what happened. This is just to show that it can be used to assess response. So this is a baseline patient, perfusion and FDG. You can see that there are areas of FDG uptake that are high, anterior wall. So this is kind of like early to mid-stage sarcoidosis. At baseline, patient was treated with steroids, and a few months later you can see that the FDG uptake is gone, perfusion normal. So basically that's good response to the cardiac sarcoid as well. So it can be used for response assessment of cardiac sarcoidosis as well. And there I'll stop. Questions? Yes?
No, I just said thank you.
Thank you.